Welcome all. This presentation will focus on our case with James following our initial consult and the implementation of behaviour change techniques to aid in physical activity adherence. From the consult, 3 significant barriers for physical activity participation were identified. These include physical disability, lower back pain, and low socio-economic background. Within current literature, the most effective BCTs for people with physical disability adherence to activity was self-monitoring of behaviour, followed by providing instruction on how to perform the behaviour and problem solving. Additionally, each BCT demonstrated a moderate effect size ranging between 0.45 to 0.40 and a significant confidence interval. Literature also indicated that there was a larger effect when interventions included self-monitoring with an additional self-regulation BCTs, which may include prompting specific goal setting, review of behavioral goals, providing feedback on performance, or intention formation. As a BCT, self-monitoring is effective at providing knowledge and feedback to individuals on their progress to achieving their desired goals and if further modifications to plans are required. The BCTs of demonstration of behaviour, behaviour practice, and instruction on how to perform behaviour were shown to have a greater positive effect over a zero or negative effect, indicating them to be the most effective for adherence for physical activity. A combination and format of these BCTs can be utilised to assist in building the client's knowledge and confidence around performing new behaviours through the use of visual demonstration, instruction, and in practice. An additional review from Marley 2017 also reaffirmed some of these BCTs as well as goal setting for behaviour as having a high prevalence for success for this specific type of population. In comparison, BCTs that produced a higher zero and negative effect were identified. These included problem solving, goal setting for outcome, self-monitoring of behaviour, and graded exercise tasks. Current literature for BCTs for people with low socio-economical backgrounds included predominantly behavioural practice and instruction on how to perform the behaviour, with both demonstrating a moderate effect and within a reasonable confidence interval. These BCTs were effective at building skills training, as the client was either given clear instruction for performing the behaviour or repetitive practice to reinforce the behaviour. Within the study, it also highlighted that when implementing BCTs, community or home-based settings produce greater effects in comparison to not in these settings. Therefore, to have a greater effect for the client, further evaluation into where the BCT will be performed should be considered. Additionally, it was indicated that information about antecedents did not produce a great response when implemented. This slide provides 2 plans with BCTs and examples that can be discussed with James in the next consult and can be potentially implemented into his everyday life. Key considerations when selecting these BCTs included using reliable literature, James's goals, medical conditions and lifestyle, his confidence when performing and adhering to physical activity, utilizing community and family support environments, providing knowledge on performing behaviours through practice, instruction and/or demonstration, and ensuring progressive adherence to physical activity can be built. Plan A primarily focuses on strategies in demonstrating, practicing, and self-monitoring of the behaviour. This can ensure that James is provided with significant understanding of how to perform the behaviour, reinforce regular practice of the behaviour, and visually see progression. Client-specific needs are met through utilizing community and or home-based settings, as James in our previous consult expressed the importance of these communities, which can further aid in building his autonomy, confidence, and adherence. In addition, due to James' medical conditions and economic background, these BCTs utilize accessible methods for completing these strategies, either through provided in-person demonstration or obtainable resources. In comparison, Plan B also prompts discussion in practicing and verbal instruction for performing behaviours, but also incorporates problem solving on ways James may wish to participate in physical activity. This can promote for more client choice and build on client autonomy. When discussing these BCTs with James, variation and modifications may be required to further support client autonomy, and/or client-specific needs.